Assalamualaikum and a very good day. In this video, we're going to discuss a little bit about diabetes in pregnancy. So the learning objective of this lecture is to discuss the definition of pre-gestational diabetes in pregnancy and gestational diabetes. So what are the differences between these two terms? Discuss the risk factors, who are at risk of having gestational diabetes, what are the complications of this problem, the goal of therapy if the patient's having GDM or diabetes in pregnancy, what are the treatment options, and the monitoring parameters. So this is the definition of both of the condition, pre-gestational diabetes and gestational diabetes. So pre-gestational diabetes, to put it in a simple way, is when the patient already have diabetes before. It's either type 1 or type 2 diabetes, and she got pregnant. So during the time when she is pregnant, she was having pre-gestational diabetes. That means the diabetes continues during the period of pregnancy. Meanwhile, in gestational diabetes, it's when the person or the woman does not have diabetes before, but during pregnancy she developed signs and symptoms of hyperglycemia, and then she needs to be further diagnosed if she's having only a transient hyperglycemia or if she has gestational diabetes. For the statistics, it might change over the years, but the latest the latest statistics from the Malaysian National Obstetric Report in 2011 and 2012, the incidence of diabetes in pregnancy is between 8 to 9%. Whereas worldwide it can be between 7 to 18% worldwide. So cesarean section rates in this group of patients were quite high, about 13%. So a high number of them also needs to get cesarean section instead of normal vaginal delivery. So in both years, approximately 16 babies were born to diabetic mothers weigh 4 kilograms or more. So we'll talk further about the complication or consequences of women when they have diabetes in pregnancy. For the pathophysiology of GDM is also similar with the pathophysiology of diabetes mellitus, in which it involves insulin resistance. But in this case, because it happened during pregnancy, it's actually the pregnancy itself is inducing this problem. So the placenta produces hormones like estrogen, cortisol, or hormone placental lactogen. So these hormones actually induce the insulin resistance in the patient. So because of this insulin resistance, it might also impair the beta cell function. So the chronic insulin resistance will eventually cause hyperglycemia, and then consequently the patient is diagnosed to have gestational diabetes. So the reason why the placenta produces such a hormones is to maintain the support for the fetal growth, and we need to supply the glucose to the fetus as well. So these hormones are important for fetal growth, but then it has, for some people, they have complications like this, like the insulin resistance problem. For the complications of diabetes in pregnancy, it can affect both mother and the fetus. Okay, for the mother, if they have pre-gestational diabetes or gestational diabetes, they are at an increased risk to have vascular disease, ketoacidosis, or preeclampsia, okay, the high blood pressure. For the fetus, the fetal might have an increased risk to be born large. Okay, so this is a big baby syndrome of fetal microsomia, which is the birth weight of more than 4 kilograms. Okay, if the baby was born more than 4 kilograms, Usually the mother is diabetic, but it's not necessarily so, but it increased the risk to have big baby. So second one is major congenital anomalies, but for this one is more likely, evidence shows it's more likely to be caused by uh, pre-gestational diabetes, in which the mother already have a diabetes before pregnancy, and then when she got pregnant, she might have that risk of having babies with major congenital anomalies. But the evidence is quite weak for gestational diabetes patients. Neonatal hypoglycemia, it's the temporary hypoglycemic symptoms for babies upon delivery. So the baby might have hypoglycemia, but then the blood glucose will increase back. So it's not a long-term problem. Respiratory distress syndrome is also during delivery. So the baby might have a respiratory distress syndrome. So we measure that using the APGAR score. So during delivery, we'll have a APGAR score for the baby to assess. And also fetal death. Okay, the risk of stillbirth is also high among women with poor glycemic control. So, but mind you that when you give a counseling to pregnant women with diabetes, um, don't you don't need to scare them. Actually, it's the risk is there for the babies to have this kind of problem, but then if they maintain or if they control the blood glucose level, they should not worry of this risk, because some of these risks are actually quite low in prevalence. Okay, so this is the pathophysiology of how the high blood glucose will benefit the baby. It will fuel um, the growth of the baby. But then during gestational diabetes, the blood glucose level is high, so it can cause also high blood glucose in the baby, and then the baby put on extra weight. Okay. So preconception care and pre-gestational diabetes. So if your patient is already have a diabetes before pregnant, and then she planned to have a pregnancy, so she planned to have baby, um, you have to counsel them to be to control the blood glucose very well. So pregnancy needs to be planned, and then it can occur only when the glycemic index is controlled. For example, here we use HbA1c, which is less than 6.5, and also they need to have a controlled BP as well before they plan to get pregnant, and they need to take folic acid supplementation at least 3 months before they plan to have a baby. And oral antidiabetics, if they are taking, for example, metformin or gliclazide or glyburide, for example, so it needs to be switched for a better glycemic control during the planned conception if they do not have a good glycemic control before. So whatever it is, they have to make sure that the glycemic control, the glycemic index is controlled. And discontinue any statins if they are using statins during pregnancy, and they need to screen for diabetic retinopathy and nephropathy. So make sure they are well and they are fit to get pregnant when they already have diabetes. For women who do not have diabetes, when they are pregnant, we also need to assess whether they have gestational diabetes. Okay, the risk factors here are those who have a BMI of more than 27 or obese, previous pregnant macrosomic baby weighing more than 4 kilograms. So previous pregnancy, she got a big baby, or she already had GDM before, or the first degree relative with diabetes, for example, family history of mother and father have diabetes, for example, or she had a history of unexplained intrauterine death. So there is a case of stillbirth. Stillbirth is when they deliver a baby, but the baby already died, and also miscarriage. So the baby is died in the womb. history of congenital anomalies, glycosuria at the first or any prenatal visit. Glycosuria is the presence of glucose in urine, or current obstetric problem like essential hypertension, pregnancy-induced hypertension, polyhydramnios, and current use of steroids. So these are the problems that um, that might increase the risk for them to get GDM. So during the screening, for those who have these risk factors to develop GDM, we might need to do the OGTT test as early as possible or during the booking. Okay, booking is when they register their pregnancy at the clinic kesihatan or any private clinics. So they will be given a book for them to follow up every um, appointment. Okay, so they need to jot down the development of the pregnancy. So for women aged more than 25 with no risk factors, they can do the OGTT test for the screening of GDM at 24 to 28 weeks of gestation. Okay, for those who have risk factors, it can be earlier because it can be as early as possible. But for those who age more than 25 with no risk factors, it's 24 or it's between 24 and 28 weeks of gestation. So they need to take OGTT test. OGTT test is when the mother will be asked to fast early the night before. Like for example, 10 o'clock the night before, they cannot take any food or any fluid, and then in the morning they have to go to the clinic to get the blood sample before they take anything, and then they will be given a 75 gram of glucose, and they have to wait 2 hours, and then they will be the blood will be taken again. So we will have 2 samples of pre and 2-hour post glucose load. Okay, and the OGTT result for the fasting, it needs to be less than 5.1. If it's 5.1 and above, or the 2-hour postprandial, the glucose is more than 7.8, she needs to be she can be diagnosed as having GDM already. Okay, or if she has a FBG of less than 5.1 and 2-hour postprandial less than 7.8, they need to repeat the OGTT test again during 24 to 28 weeks. So if it's no, then she's cleared of GDM. But if it's yes, then she can be diagnosed as GDM again. Okay. For the diagnostic criteria, I mentioned before, the fasting blood glucose is more than 5.1, and 2-hour post glucose load is 7.8. So these are the readings after the woman take the glucose load, okay, or GTT test. So the goal of therapy for women with GDM, so we want to target the glucose level. For the fasting, we want to be less than 5.3, or maximum is 5.3. 1 hour after meal, 7.8, and 2 hours after meal is 6.7. Okay, and the HbA1c is the same like the patients with diabetes, which is less than 6.5. For the management of GDM, so when the woman is firstly diagnosed with GDM, we do not give medication straight away. We do not give insulin, or we do not give any oral antidiabetic straight away. We ask them to do a diet therapy first. So it's called diabetic diet, and the aim is to achieve and maintain optimum glycemic level. Okay, and also meeting the essential nutrients to promote positive maternal and fetal outcome. So it's the only thing that is different between GDM and DM is that we need to also take into account that this pregnant mother also needs to gain weight, to as a sign for a healthy development of the baby. Okay, so during the follow up, she always needs to be weighed, so that we know that there is an increase in the weight appropriately. So there are some calorie requirement for them, so you can have a look, you can have a background reading later on. And for the weight management, for the so they have like a different range in which is tolerable for them to gain weight during the second and the third trimester, because during the first trimester they won't be much change, because the baby is very small at that time. The only change is that the formation of the organ of the baby, so there's not much change. Only during starting second trimester that the baby is going to thrive in, or grow in size. So for the so these are the chart for them, which is the tolerable total weight gain and rate of weight gain. So what happened when the diet therapy plan is not working? Okay, so it's also the same with diabetes, in which after the diet therapy fail after 1 to 2 weeks, and they should be started with medication. So it's also the same. And during this GDM diet therapy plan, the woman needs to be monitored. So they need to do a self-monitoring of blood glucose. We will see that later, the SMBG. So this is when they need to do the needle prick to get the blood glucose level. So they need to read it every week. So they will do so it's study of monitoring for them whether they achieve the required fasting blood glucose or 2 hour postprandial. If it's not controlled based on that reading of the SMBG, they need to be started with either insulin or any oral antidiabetics. So for the insulin, it is actually the gold standard of GDM treatment. Okay, so once they fail the diet therapy after 1 to 2 weeks, so they can be planned for insulin therapy. So the dose, like the diabetes, the dose needs to be adjusted according to the blood glucose level. And in some patients, they need to be admitted to the hospital to institute an individualized insulin regimen, because we need to monitor the blood glucose very carefully. So because we want to avoid the hypoglycemic effect. So there some women, they need to be hospitalized to make sure that they have the a proper regimen, insulin regimen for them. So once they are stable, they will be discharged with that dose. So multiple daily insulin is the best way to control blood glucose during pregnancy, because we do not want to risk the patient with the long acting insulin, because it's quite hard to adjust. Okay, because if they take a multiple daily injection, the dose the it is a short acting, so the dose can be adjusted at any time of the day according to the body's need. So it does not cross placenta, because it is a endogenous substrate. We also produce insulin ourselves, so it does not cross placenta. It has established safety record for both mother and fetus. And insulin should be continued during pregnancy in women with pre-existing diabetes who are already on the treatment. So if they have a pre-gestational diabetes, they're already on insulin, so we can just continue the insulin. So how to initiate insulin therapy in pregnancy? So when the patient is the first time insulin user, we can start with so it is based on the on the patient's fasting blood glucose and either 1 hour or 2 hour postprandial blood glucose level. So if they have a high fasting blood glucose, so it is more appropriate to start them with insulin at bedtime, okay, the intermediate acting insulin at bedtime, because it will cover the morning, which is the fasting blood glucose. Okay, start with 0.2 unit per kg, and we monitor, can increase by 2 units every 3 days, okay. So for those women who have a high blood glucose after food, 1 hour or 2 hour postprandial, so they can be started with a short acting insulin. Okay, start with 6 units, increase by 2 units every 3 days. Okay, so these are the types of insulin that can be used: short acting like rapid, okay, rapid, intermediate acting like insulatard, Humulin, and Insugen, okay, and long acting like glargine. It says here that glargine can be used because this is from the guideline as well, but then in practice it is more preferable to start with intermediate acting insulin like Insulatard or Humulin N or Insugen, because we do not want to have a risk of hypoglycemia due to the long acting insulin. So now we come to the oral antidiabetics used in treating diabetes in pregnancy. So previously, in a few decades ago, we do not have a clear evidence or a clear result for study from human studies that shows that metformin is safe to be used during pregnancy. Because previously the results or the evidence is based on animal study, but nowadays we have quite a number of studies which is done in human on the safety and efficacy of oral antidiabetics in pregnancy, and it shows that metformin is the most preferred oral antidiabetics to be used in pregnancy. It has a good efficacy as comparable to insulin, and it's also safe to be used in pregnancy. It does not show any significant difference in terms of the glycemic control as compared to insulin, and it also has some favorable effects like a better maternal outcome in total weight gain, for example, the postprandial blood glucose control, and also it can cause less pregnancy-induced hypertension. And it can also has a lower risk of severe neonatal hypoglycemia. This is the fetal risk before. However, it can increase the risk of preterm birth, okay, as compared to insulin. But also we have to take note that when we want to give any suggestion or any treatment to the patient, we need to have the patient to be involved, because they are the ones who are taking it. So in terms of the compliance of the diabetes management or diabetes therapy in patient, we need to know whether they are willing to take the insulin injection, or they want to take a tablet. Okay, so both option is acceptable, and if the patient is not uh, does not prefer the insulin injection, oral antidiabetic, which is metformin, might be the treatment for her. So there is no clear-cut recommendation whether to give insulin or oral antidiabetics for gestational diabetes. So it depends on many factors like the blood glucose control itself, and also the patient's preference. What are the previous evidence, for example, and what is history, the history of pattern of glucose control history, for example. Okay, but metformin can be one of the option for those women with gestational diabetes. On the other hand, for pre-gestational diabetes, which is the woman who already have diabetes before and she already take metformin, for example, to control her diabetes before, she can continue to use metformin during the pregnancy. And of course, regardless of which option, they need to monitor the blood glucose. For the metformin, the initial dose can be 500 milligram OD. It can be increased up until 1500 milligram OD. And we can also use SR or XR. It's either BD or OD. And for the use of glibenclamide, it's not recommended because of the poor safety profile. And also you have to take into account one of the monitoring for pregnant women with any problem is also the delivery plan. Okay, so because in the end pregnancy is only temporary, so in the end it will end up with delivery. So for the delivery plan for pregnant women with pre-existing diabetes without complication, she can be planned at 37 to 39 weeks. But if she had a complication, it needs to be earlier, so before 37 weeks. So pregnant women with GDM, those with diet control and no complication, the delivery can be planned at 40 weeks. So this is the common due date, okay, 40 weeks of gestation. And for those with oral antidiabetic or insulin therapy, they should be planned earlier, which is 37 to 38 weeks. But if they also have complications, it should be before 37 weeks. Okay. So as I mentioned before, we need to monitor the blood glucose regularly. So it's called self-monitoring blood glucose, SMBG, or BSP, blood sugar profile. So when they are undergoing any treatment, even during the diet therapy or the insulin therapy or the oral antidiabetics, they need to monitor for the blood glucose regularly every week. And even more for those who have a pre-existing diabetes on multiple daily insulin, they need to monitor 3 times daily, which is fasting, preprandial 1 hour, postprandial, or bedtime. So any of this time, 3 times daily. Okay, we need to monitor. And for GDM with multiple daily insulin, we need to monitor 2 to 3 times per day for 2 to 3 times a week. And this is it's like the same with those with diabetes mellitus. Those with diabetes on insulin, they also need to monitor. They need to get the blood glucose level before they take the insulin injection. For GDM on diet or oral antidiabetics or single daily insulin, is fasting and 1 hour postprandial once daily until the blood glucose target is achieved. So for pregnant women, before they went to the follow-up at the clinic, the doctor will review their SMBG profile or BSP, and they need to take it at any days before their follow-up at the clinic. So they come to the clinic with the results that they already did a few days before. So the doctor will review, and then the doctor will decide what are the next plan. The glucose level should be more than 4 millimole per liter because we want to avoid any risk of hypoglycemia. Okay, so it needs to be more than 4. For postpartum management, we still need to monitor the patients because in some women, the diabetes that occurs during pregnancy can continue even after they already delivered. But in most cases of gestational diabetes or GDM, the insulin resistance will no longer be there once they delivered, because it is induced by the hormones during pregnancy. And insulin therapy can be continued when the blood glucose is stabilized or returned to normal. But when the therapy is still needed, the non-breastfeeding mothers can continue with oral antidiabetics if they are using metformin. If they do not plan to breastfeed, then they can continue with metformin. But for breastfeeding mothers, they can use a low dose of metformin. And when breastfeeding, if glycemic control is inadequate with diet therapy alone, so insulin therapy should be continued at a lower dose. Okay, if they cannot be coped with diet therapy alone. And the women with GDM, they need to undergo MOGTT test again after 6 weeks of delivery to make sure that they do not have a diabetes even after they deliver. So, and also annual screening for type 2 diabetes, because GDM actually increases the risk of a mother to develop diabetes mellitus later on. And these are the references. Thank you very much.